Welcome everybody to this meeting of this Upper and Integrated Care Board. I first ask for any apologies for absence. Jamal.
So got Jamal, Vanessa Ford and Jonathan Bates.
Bob, you need to go somewhere.
Yes.
Declaration of interest. Is there any declaration of interest relating to anything? Agenda?
Sorry,
Yeah.
Yes.
Minutes of action log. Rising. Benny, do you want to?
I don't think there are any matters arising, and so just to people who.
If there's any comments on the minutes?
Yes, comments on the minutes.
Okay, let's take those minutes as approved. Ben, decisions made in other meetings.
Thank you, Anne. Shall I, in terms of expediency, take the paper as read? The paper sets out the decisions, but we've made in separate meetings. Very happy to take any questions.
It's quite straightforward. Okay, let's move on. Cyber assurance activities. Martin, you're going to take us through this.
Yeah, thank you. And so taking the paper as read, I'll just give a few highlights. So since we had the strategy agreed a year ago, we've agreed 9 supporting policies and 3 standards with providers locally. We've also set up a cyber assurance group with representation from all providers. And that reports into our digital board, South and Southern Digital Board. Through that governance, we've been able to secure significant investment for cybersecurity in the past this year. So more than double we've had in the past few years. So we're seen as sort of being very proactive in managing cybersecurity across South West London. So we've secured £1 million this year, which has been really good from national funds. So there's 2 sort of roles here for ICB. There's one about the system sort of oversight, and there's one as a provider of IT to IT to GPs and to corporate team. So within that, we had to follow the DSPT, so the Data Security and Protection Toolkit and the Cyber Assurance Framework. And so we have created our own KPIs and a dashboard to be able to have visibility across that, and that's in the pack. And we've completed the Windows 11 migration on time. By sort of October last year, when Windows 10 became unsupported by Microsoft, which I know has been a struggle for other organisations. So that's a good success. So what's next? Managing risks with third parties. That's probably where the biggest sort of cyber risk is at the moment. So we know from the incident that happened across the way in South East London, there was a third-party vendor that was impacted. So within the sort of NHS family, it's a lower risk compared to those outside it. So there'll be a lot of focus on managing third parties over the course of the next 12 to 18 months. There is funding through the new Frontline Productivity Fund, which is the 4-year capital and revenue investment for digital of £2 billion nationally, which London gets 280 million. And cybersecurity features strong in that, so along with other digital areas. I think there's probably a need to manage, well, there is a need to manage a transition of responsibility for the ICB as we move into strategic commissioner and some of this responsibility transfer to providers. So that's something we'll be focusing on in the next few months. And then also be looking to provide this board with some training around cybersecurity in the future seminar. Happy to take questions on the paper.
That's okay. So can you just say more about our role in the future and how that fits with our EPR, our emergency planning role?
So we need to make sure that our responsibilities track with what our EPPR responsibilities are we a level 1 responder or not?
Yeah.
At the moment we are a level 1 responder, so we're coordinating a response to a cyber attack. But as it evolves, we'll need to look at where that responsibility transfers in the new environment.
So we're not clear about that at the moment.
Not at this point.
Okay, that seems like quite a big issue in terms of you know, us migrating from the 1st of April into this new role, but something as critical as this not being clear. So what is the?
Well, so I think where that is the case, it's nothing changes till everything changes. So until that becomes clear, we still assume that we retain the same accountabilities that we currently have.
And we will still have.
Because that level 1 will be in legislation somewhere, I'm assuming.
I assume when legislation changes for ICBs.
So the in terms of EPRR, our Cat 1 responder is in the Civil Contingencies Act, and that was changed a while back. Our understanding at this point is that that is going to stay the same. So ICBs are going to remain as Cat 1 responders, which is partly the drive for where we are keeping our SEC and EPRR provision for the future as well.
And any cyber incident then would trigger that response. Yeah, okay.
And there will be resource within South West London system to be able to support that requirement as a strategic commission.
Yeah. And can I just ask about primary care? Because obviously we have, as you say, a direct responsibility for primary care. Just can you say a bit more about how we're assuring what's going on? You know, I can remember WannaCry and all the patching issues in primary care and how vulnerable we were. And I've no doubt we're in a much better, position now. But it's quite a diffuse workforce, isn't it? In terms of
it is, and probably to the frustration of primary care, the more we tighten access to the system, the better the cybersecurity is. And so not allowing access for or controlling access to personal devices and third-party solutions, so that we ensure that they are secure, because that's probably the route in to a cyber attack for primary care. And in the dashboard, you can see that is our assurance for cybersecurity around primary care. And we can see that there is some areas which are related to software upgrades that we're a little bit behind on, but mostly we've got strong assurance for primary care.
Yeah, so there's building up something here, isn't there? Because we've got immense frustrations in primary care when we can't do things ourselves, and which really hampers advances. And primary care is quite nimble in terms of taking on in digital new ways of doing things, the automation, all of that. And actually, by making it safe and secure, we're restricting their ability to do that. So I think possibly the job is about ensuring that primary care understands that tension and rights of being educating them, because the more open it is to enable them to do that, the more they have to take responsibility for cybersecurity themselves, which is, a different set of issues. So I think it's about the communication that we have around that and supporting primary care to be able to do what it needs to do, but safely.
Yeah, it's striking the balance, isn't it? It's about it's a risk assessment, risk approach, but we don't want to stifle that innovation within primary care, but we also want primary care not to be impacted by a cyber attack. So striking that balance.
I agree with your assessment that the most likely route in is a third party, but also primary care. Because of the nature of it.
Do we have an understanding of within primary care? Because I know we've said that laptops that haven't been used for 6 months are going to qualify for the refresh. And at the moment, we've got almost 25% of laptops that haven't been upgraded. I'm assuming that when we do the upgrade, we upgrade to Windows 11 and we do the patches and everything. 25% is quite a lot. Of that 25%, how many of those are ones that, if you like, have been offline? How many of those are offline?
Yeah, so we can upgrade remotely, but if they haven't switched the laptop on, we're unable to do that remote upgrade.
What's the plan?
So soon as
You
they,
know who they are.
Yeah.
Because of the asset management systems we've got.
Yeah.
But how are we tackling that to ensure that we're getting them upgraded as soon as possible?
so it's an ongoing piece of work with each of the practices to be able to identify those and talk to those practices about doing that upgrade. So it's, so it's ongoing. Well, I guess over the course of this financial year, before end of April, end of March, I should say.
And then what happens to those laptops that haven't been turned on?
So I mean, they don't pose a risk if they're not being used. Once they're turned on, it will trigger an automatic upgrade. So I guess it's a low risk from that point of view.
Very much.
Thank you.
Board assurance.
Thank you, Anne. So, as the board knows, we take the board assurance framework at all of our meetings, and it is a living and ever evolving document. And very much, you'll see that we've changed the way the format of it this time, and we are expecting that it will iterate over the coming months. So, as the board will have recognised, this is different to the previous version that you received. So we've now refocused the BAF. So the BAF is providing you with an overview of the principal risks that are facing our three corporate objectives. We've done a new format for the BAF, which I hope is provides more clarity and transparency for the board in assessing those risks. You'll recognise the format of it, I'm sure. Still provides you with a risk description, the causes, the impact, etc. But I think, as you'll see on at least the second page of that, we're also outlining now where the board can take its levels of assurance from in trying to mitigate each one of those risks, and we will continue to iterate that as we go through the next rounds of this, particularly making sure that each committee is clear on the risks that it owns on the BAF, and again providing that assurance back to the board. So we took this through audit committee yesterday. We're very slightly out of sync with the way we're running this through, just to get ourselves into this new format, but we discussed it in detail at audit committee yesterday, and then we will go through the run of committees going forward. It's also worth just noting that we've implemented a new risk working group in the organisation, which Katie chairs, which has been through all of these risks in detail, has been leading the redevelopment of the BAF, and that's really our in-depth challenge at exec level to each of these risks. We're going to flow on now that we've completed this review on the BAF to look at the corporate risk register. So to make sure that the corporate risk register is really looking at the principal risks to our operational delivery within the organisation, and within that we'll then be taking specific areas of risk, for example looking at what risks we've got in place or specific programme risks within that. I won't go through the detail of each of the risks, I'm sure you're pleased to hear, but as you know, we've got 6 risks on there, and I'm sure exec colleagues around the table will be very happy to take any specific questions on that if the board have any.
Was there anything from the audit committee to bring to our attention?
Well, we had a pretty good discussion about this actually. I thought, the suit told me I'm wrong.
No, he's not in.
So we did. So there is something that recognises that to a certain extent the BAF of this year is what it is. We were comfortable with the reformat of it, but in discussion it struck us that there were 3 big things that, to Ben's point about this being a living document, we will have to continue with and land. So firstly, no authority, but in the order that I can remember them. Firstly, there's the piece that says, as we change the role of the ICB, either some risks that we have been holding as an ICB risk cease to be ours, but that doesn't mean they're no longer a risk somewhere. So there's something of the duty of care of being able to hand over a risk as well articulated and as well narrated as to what's been happening to mitigate it. So whatever the party receiving is. You've then got risks that say, well, they still exist, but suddenly our accountability for it changes. So actually, we've got to change what risk we're assuring ourselves against. And then, of course, then there's going to be potentially risks as yet undefined, which are what happens when we move into new planned territory and things emerge, and we as an ICB have got to respond to that. And that's the bit I think we've got to keep on top of. So I don't think we don't have to worry about that anymore. All we worry about is this. But there's a recognition that while we're closing down risk, we're opening up for the new world. And it strikes me that we need to get the coordination of that right. And be absolutely clear with whatever governance structure emerges in the new world, that we've got the right committee structure owning the right risk, and then audit assuring on behalf of the board that people are doing that appropriately. So I think there's a closure piece and there's a creation piece, and that feels to me like what the next 6 months is.
So I agree with that completely. I think that's probably the biggest risk actually facing all ICBs is that transition, because I hear a narrative quite a bit, not unique to South West London, of, well, it looks at as ICB as it will be rather than as it is now, but it looks at the rest of the system as it is now, and therefore there is a real gap, which is to Bob's point around that transition, because actually if no one else is ready to take the risk we want to hand on, then we're going to have to, as a strategic commissioner responsible for the outcomes of our population, hold it, but in a different manner. And there's a risk, isn't there, that we say, right, okay, we are moving or have moved to new set of responsibilities, but actually the rest of the system hasn't yet moved to the same place. So this year is absolutely, that's probably the overarching risk, is the kind of send and receive bit.
Sticking sender and receive.
Yeah, it's very much, that's exactly what occurred to me.
Essentially, what we would be saying, if I understand it correctly, is that that we would, from the statutory point of view, we remain in statute accountable, but we may choose to transition or delegate the accountability for monitoring that risk in year.
Yes.
And
Absolutely.
what you're alerting us to is the needing to be very structured about that, which I know Ben will be familiar with doing.
I think to Bob's point, being very cognizant of the way we take assurance around that then might change. So as we're not bursting, because if you were going to outsource CHC, it's not like, the fact that we would do that for fact management group forming structure in a different way than we might do it to actually hold it within the organisation, for example, I think, and we just need to be cognizant as we, and I guess to, the earlier conversation with Martin, some of those slightly greyer areas where we're very clearly sort of to speak to us in a minute about our APRR responsibilities as account one responder in that, but the side of it is more of a policy sphere from NHS England and how we make sure that we've married them up and not lost anything in it.
Yeah. And so we obviously need to do that piece of work, and I think what I'm understanding is then these risks are going to come back through the committees. And so when we meet again, our next board meeting, we would then look for the committee chairs to be starting to comment on those risks soon.
So just a question really about, as we iterate, and as we start to triangulate the data that we have in order to determine what our level of assurance is. With inequalities, do we have enough visibility to ensure that actually we're not widening any of the inequalities? So even though overall we may feel we're making progress, how do we mitigate against widening those inequalities?
Elaine and Larissa coming on that.
I think that's something that we need to be mindful of as we move forward. You're right to raise it, and it's something that we need to be cognizant of as we work through it, to be honest, I think. I know our partners work really closely together, that we on EQIA, they're essential to understanding impact and then mitigating that. But if we're not collecting that data and aware of the potential issues, then we're going to blunder into something unintended. And I think you can avoid that by sort of being more mindful of what we're doing. Yeah.
But I think, to Bob's point, part of this is in transition, because once we have completed the work we're doing around the CLSP, actually that the products of that become the strategic objectives at which you assess the principal risks through a board assurance framework. And that piece of work, as its founding principle, is a specific and explicit focus on reducing inequality. So then that will be, the lens through which we look through all of it. But this is the transitionary period in the absence of a strategy, and therefore principal risk of delivery of the strategy. So it does get sorted. But I don't disagree. You're right to flag it. We must really hold it very carefully in the intervening period. But once we have the strategy, which we're really close to, and the articulation of the risk, principal risk of delivery of the strategy, and that strategy is completely constructed on the premise of a specific and explicit focus on reducing inequalities, I think we will have much more points of triangulation of which to be assured.
Thank you very much. Shall we move on a bit with EPR? Oh no, we've got board members' lead roles.
We have, and I can be relatively quick around this, but Aaron, you specifically asked for this just to remind the board what our lead roles were, both in a sort of strategic policy sense from NHS England and from statutory sense, what's stipulated in that. It is something we bring back to the board on probably an annual occasion, just to make sure that we are open and transparent and everybody knows who's leading on what. And I've reminded all of the execs exactly what they are leading on and government. So yeah, I think it's fair for information and any comment.
In all this transition.
I know it was good. We may well want to come back to it lightly as we move around.
But this is another example of, let's be clear where we are at the moment. But then as we, transition, we need to be very mindful about how we're moving these responsibilities around on the basis we just discussed. Okay, let's take that as nosy. Emergency preparedness. Yes, but you come.
Oh, I'm just ahead of you. Hi, for those of you who don't know me, I'm Lisa Haywood. I'm the director of UEC, and I'm here to present the assessment of the EPR against the EPR core standards. I'll take it that you've read the paper. Just to give you a very brief overview, we've been assessed by NHS as fully compliant, which is fantastic. It's worth noting that normally there is a deep dive component to the core standards. There isn't for 25-26 because there is an acknowledgement of all the change that's ongoing currently. But for London region, they did include a EDI core standard, which again we're fully compliant against. That said, although it's heartening, and there was a lot of positive comments back from NHS, the risk environment is complex and it's becoming more and more complex. Our risks, as you'll see from the paper, are particularly with regard to cyber, of which we now have a cyber annex that sits alongside our core standards. Also supply chain management, because of a lot of the changes in procurement and the way that we manage procurement through the London Procurement Hub. And then also the severe weather and the impact that was having on services. What I am really pleased to report that NHS went through all of our mitigations that we have in place, and we again fully assured that we have the mitigations in place and that we continue to really work as a live team and take all the learnings we possibly can. So really, that's positive. Okay.
In terms of provider preparedness, how do we manage variation? And what do we actively do to support?
It's a really good question, and actually the core standards of the set this year, we did incredibly well. The two areas where we didn't fall down because we still received partial compliance were particularly around the data protection tool and also, again, supply chain management. But within the standards, you can assess really clearly where we are as providers against those core standards, and then we take those back and we take them into the learning and the training, the discussions that we have with providers on a sort of quarterly basis, and play back as a system in terms of what we see.
And quite picked up on the data protection side of thing with DSPT. Is that that's on the provider side rather
It
than
is very much
ICB
on the
side?
provider side. There is debates about whether it will stay as an EPR core standard or whether it will move more into the IT side of things, but that is where it sits currently.
Let's go back to the various exercises that happen periodically. So what's the mechanism, or how assured are we about the mechanism for the learning from exercises to be embedded? So what's behind my question is that I know with various exercises relating to pandemic, but obviously availability of PPE was something which was often raised, and yet obviously it was an issue, no doubt, because of the scale and speed of what happened. But how do we take the learning and make sure that we're prepared for it?
Yeah, I guess there's learning on two levels. There's system learning, so there's the learning that comes from the sort of the command structure, if you like, into the sort of senior leadership of organisations, of which we've had 3 exercises this year, and we have taken that back into trusts and provider trusts in particular in terms of the learning from that. And then there is the local development training packages that we have that are regular. But in terms of the learning, it's challenging, but we can triangulate the learning that's come out of it and how it's then related to a real live incident, of which unfortunately we do have quite a few, particularly in BCI, and we do triangulate that learning to make sure that where it's come up in an exercise, if it's occurred in a real live incident, what can we take from that? Am I making sense?
Yes, yeah.
So we do triangulate in terms of the real life environment, I guess.
Yeah.
Yeah, thank you. And thanks very much for the report, very, very clear. If I look at the risks and challenges that you articulate, I mean, none of them look like they're going away. And then when I look at the table of performance, you see organisations who either haven't been able to improve between years, or in some cases have actually performed at a lower standard from 4.5 to 5.6. So, because I'm a sort of a pessimistic sort of an individual, what am I looking forward to when I look at this for 6.7 and 7.8?
Yeah. So where organisations have fallen down in 25-26 is particularly around the data protection tool and the supply chain management. I think we're assured, NHS are assured, that we have plans in place. If the standards stay, I would expect the providers to have achieved those. And my hope is that we'd have no deterioration. I think if anything, we should go up. But it is an incredibly complex environment. Those issues are going to get more and more challenging. But I think we're becoming much more inept at how we manage and understand cyber in particular. And with as we go back to the commissioning organisation as well, I think we'll grow that expertise in the commissioning and supply chain management environment. I think that's really important, and hopefully will give us some more rigour in terms of how we manage particularly the procurement side of the supply chain management.
I think it was just for the board to know, I mean, not to question so much, Lisa, and would agree with everybody else. Report's really clear. Thank you for all of your effort. The SCC particularly has been well tested in recent months with the level of system pressures that we've experienced. So thank you for that. But it was just really for the board to note that obviously this is a debating point across ICBs nationally around the model ICB blueprint. And there's been different iterations of the blueprint where SCCs and EPR have been split or kept together, have been retained as a key responsibility versus things that were proposed to move, either for reasons that I've provided. Just wanted to provide that assurance that our plan will be to keep that in-house. It's a system that works well. It works well for the system, responds very well. So it's to that point Andy spoke about before, until there is any legislative change, and actually we anticipate the legislation will retain the category 1 response status for ICBs anyway. We are assuming no change, and therefore building on the strengths that we already have around the SEC and EPR functions within the new structures moving forward.
Thank you. Thank you.
Thank you.
Okay. So let's move on to board committee updates. Donna, you're going to start with this. Obviously, we've got apologies from tomorrow, but
thank you.
Over to you.
Thank you. So the Finance and Planning Committee has met twice since the last board meeting in November and December. At the November meeting, received an update on planning as to where we were at that point in time. In terms of in-year delivery, the ICB financial plan remained on plan, and the financial recovery group reported on progress in relation to mitigation of risks to plan delivery across the system. As the ICB this financial year remains responsible for coordination of the system control total. At the 17th of December meeting, reported against the month 7 position, which again was on plan and no change to messages there, and keeping the forecast outturn, confirming that we would be keeping the system forecast outturn for the system at break even for the 25-26 financial year. Obviously, from a month 9 point of view, that is the time to formally review whether you think you can achieve your forecast outturn or not. So December was our time to do that, which we did confirm. In terms of our assessment on risks to non-delivery, we remained at a level of our overall plan. We remained at a level that would allow our deficit support funding to flow and support the system with cash and to achieve a break-even plan. So that is in place also for Q4. And at the December meeting, the committee also reviewed and approved contracts in line with the responsibilities of the committee, with a particular focus on delivery of the South West London mental health strategy for community and voluntary sector partner contracts. So that's what was there.
Any dates or questions for that? Finance report.
Thank you. So again, messages remain unchanged for month 8. The ICB hit all of its financial targets in month 8, with the exception of cash held, which was slightly higher than our target due to new ledger implementation, and is consistently improving back towards that target. And the system position also remained on plan and forecasting to be so. Additional funding in Q4 allowing us to spend additional money on performance and waiting list improvement through additional activity in Q4, with a particular focus on 52-week waits. And whilst we expect to manage all our risks in relation to plan delivery, as we've said previously, a large proportion has been non-recurrent, which must change going forward through delivery of productivity opportunities and also transformation from the clinically led strategic plan. From a capital point of view, we also expect to remain within our capital resource limit for the system. We do have quite a bit of money still to spend in Q4, which is typically the plan, but we meet regularly as a system through our capital investment group. We met yesterday and we received assurances that we will be able to spend as planned, and we have a small underspend, and we considered priorities of bids against that underspend yesterday, which has been agreed. So we do expect to spend our capital resource limit to plan also in this financial year. Questions?
Thank you very much. We're in various forums, we've had a chance to talk about this, but yeah, I think we didn't think we'd be in this position this time last year.
Well, as Dinah said, so we had financial recovery group earlier in like the week, and towards the back end of the year, we focused predominantly on risk identification and risk mitigation to land. And it's clear that an awful lot of people and an awful lot of organisations have worked enormously hard to get to the place that they are. But and even where we still have got residual risk, we can see mitigations to deliver what we said we would do at the start of the financial year. Of course, how we're doing it is different to how we plan to do it. And we know that the 6-7 challenge is at least in part caused by non-recurrent benefit from previous years not being available. And to Dinah's point, that people get it intellectually, of course they do, but it's actually translating that into recurrent action that reduces the need to look for non-recurrent items. Although, frankly, you will always have non-recurrent benefit, and you should recognise that. You shouldn't predicate your plan on it. No. And that's the piece going forward, and that's what we'll do to the end. We have another FRG towards the end of the financial year, which I'm hoping will be a close-out meeting to give confidence to those in another place that we plan where we said we would plan.
Thank you very much. Can I move on then to quality and performance and suit?
Thank you, Chair. I think the paper has read the areas being discussed at the last commission meeting were ED performance, discharge, safeguarding, and QA governance. And risks are continually being kind of assessed around SDEC, frailty, mental health pressures. I would like to just mention that we've started to pull together a triangulated risk report, which has given us a clearer picture from a system perspective of what's happening across the provider landscape. And I'll stop there and hand over for the quality report. Elaine, the this isn't here.
No,
You are. Thank you.
thank you. Yeah, I'll take the report as read. Highlights are the operational pressures in terms of urgent care and the impact on patients and indeed staff for that. Infection prevention control, most of our acute providers have had considerable pressures in terms of flu, a little bit of COVID, and some extensive norovirus in some of our organisations. So work continues with that, alongside some of the other pressures in terms of antimicrobials and C. diff and infections. So the IPC team support colleagues across the patch about that. You'll see from the report continued concerns around CAMS waiting lists and the issues associated there. The robustness of our EQIA processes and importance of those as ongoing, reassurance around those. You'll note CQC activity across our provider organisations with a visit to Human Services Maternity Unit recently, and CQC colleagues at across the GESH group. Epsom St Helier and again at St George's. Never events, only one report in this reporting period, but the patient safety team do quite a lot of work in terms of shared learning and never events, similar themes across all our provider organisations, so sharing that learning. Special educational needs, the challenges around capacity and capability of our teams, and inspections. And then, of course, maternity can be a significant focus with some of our trusts still on a national support programme, namely St George's and Epsom St Helier. Epsom St Helier will come off the national supporting programme, but St George's will be remaining on the new programme for a little while, and all our trusts are working towards compliance with the entity.
Questions? Can you just say a bit more about the CAMS waiting lists in terms of what our plans are around
that? Yes, we have significant lists about CAMS waiting lists. I'm going to look to Katie to support you.
Yes,
yours.
yes, so that's not. And I would also look to Jonathan if he was here, but Philip is smiling, so I know he's going to want to say, he's going to want to say something. You know, I think that we have an eye-watering increase in demand and referrals, and you know this absolutely needs to be part of the work that we do with the CLSP, because at the moment everyone's going through the same funnel, which is meaning that actually those with the greater security are waiting far too long, sometimes behind people that might be presenting with a lower level of acuity, still with absolute need, but that could be met through a different route. So this is part and parcel of the work that we are doing to look at increasing demand, cost pressures associated with the increasing demand, the right to choose impact in terms of having to move into private provision where there is less assurance around quality outputs and quality specifications because of if you hold a contract anywhere in the country, then it comes from the right to choose framework. So there is a big piece of work that we are currently underway with. It was one of the areas we're talking about where we've internally seconded people across from one part of the organisation to another to do this dedicated work, really get underneath the total area of demand for child management services, where it's tricky to clear that one. But I think as we have a expert in the room, it might be helpful to Philip, you might want to comment, you might not want to, and Nicola might want to.
Well, in terms of quality assurance, what was on my mind was, given that picture, and I'm absolutely clear we need to do the work that you're describing, how, as you know, as an ICB, an emerging commissioner, are we getting assurance on managing the clinical risk that's on that waiting list? And I don't know if that's something that quality committee's looked at, but it would be good for it to look at. But
so I mean, I think there's two things. So what's named particularly called out in this report is the inherited waiting list from the service that's moved over from a local, an external supplier into us. So what we're doing at the moment is working through those patients on that list and looking to see how we can essentially do a waiting list initiative, which isn't a normal mental health. So what we're trying to do is to work with ICB colleagues, see if we can pull money through to enable us to catch that backlog that we've inherited up. In parallel, what we're doing, and the child and adolescent services have put in place, is what we call waiting roll calls. So for those people who have been waiting a longer length of time, to physically reach out to them and obviously their parents and guardians to assess their ongoing need and either signpost them to other areas for that immediate support in the short term, or to reprioritise the level of urgency and bring them forward. ADHD is a standalone problem, which of course is national. We were signposted yesterday commended, I should say, to look at the work that Surrey and Borders have done. They've apparently done something unusual that's made a difference, which is on my to-do list to do. And I think the problem with ADHD is there's sometimes a view that it's a bit benign, but we know it's not. But people waiting for great lengths of time for a diagnosis and medication can suffer great stresses and problems. So we mustn't see it as a benign waiting list and treat it as a norm, which we've said earlier in this meeting. So that's the other thing we're trying to work with ICB colleagues on. But following yesterday's conversation at National, we will be reaching out to Surrey and Borders. It doesn't quite answer your question, but I think hopefully the waiting well bit gives you some reassurance that we're just not sitting there letting people fester to fall into better work.
Additional thing to note is when people on those waiting lists are usually very reliant on their GP practice or their ongoing care, because that's where their family sits. And I think that's a really important thing. It's kind of made invisible, because for the GP, they're not on the waiting list, they're just person with family that they've been dealing with on an ongoing basis. So we don't really we don't measure that. So
Andreas has hand up.
Andreas.
No, thanks. I mean, my question more or less answered, but just for the record, I wanted to also explore, in the CAMS backlog, what are the plans to address the backlog? But I think it's more or less has been answered already. Thank you.
Thank you. Okay. Shall we move on to the performance report? So Do you want to come up and join us again?
Thank you.
Good afternoon, everyone. Thanks for having me. I will take the performance report as read, but draw your attention to the areas where we've seen improvement and areas where we're a bit more challenged. And of course, the December report covers October and November data, so we'll want to have some December context from what we know is available already, and I'll include some of that. So first of all, on a general note, the ICS collectively is still a positive outlier relatively against most metrics. However, that doesn't mean that we are where we want to be for any of our performance metrics. I would say in particular, so for UEC, we're always above median. For RTT, we are top quartile, and for cancer, our providers are among the best performing nationally, which is great, and largely in part due to our cancer collaborative RM partners who are brilliant at what they do. But I'll go into a bit of detail about each of those areas now. So December, we saw the expected sort of lull where patients didn't want to come into ED. A bit of a performance improvement, but not something to get too hopeful about, is it? Because it's the normal sort of seasonal variation that we might see at that time. There are indications that some of the interventions taken have had a positive effect, such as the integrated coordinated care hubs that have been set up at LAS. And of course, although they target mainly the elderly, it's a relatively small cohort, but we know the huge impact that each one of those patients has. So keeping them out of hospital and well at home is a key feature of the UEC programme that the ICB hosts. Two of our trusts have recently been in tiering, that's George's and Epsom and St Helier. St George's moved out of tiering, and Epsom are receiving extra support from NHS to move out of tiering. This morning, they've had their 5 exit criteria confirmed, and so they've got a clear pathway to coming out of tiering in the next couple of months, we think. So that's UEC. We aimed for 0 52-week waits by the end of December, supported by, 65-week waits by the end of December, supported by NHSE. We didn't quite reach that, but NHS England were really pleased with our performance as a system. We ended December on 50 65-week waiters, and this was the anticipated number. We talked to NHS England every week. We knew that around 50 patients probably wouldn't want to come in too close to Christmas and New Year for their treatment, which is a shame. But we are still on a good trajectory. We've talked a bit about the non-current funding that's coming through to support a continued recovery in that against that position. And there is now a Q4 sprint, and more money is becoming available, in particular to look at insourcing and outsourcing in the private sector. So we hope to see a further improvement on 65s and on 52-week waits by the end of the year. Cancer standards were a concern. RM partners stepped in to help our providers develop recovery plans, and they have improved, which is great news. And in particular, our patients over 62 days have decreased, and they're now close to the planned levels that we were looking at for December. So I guess the areas of challenge I draw your attention to are diagnostics. There's a lot of pressure in the system at the moment. We always say it's the most pressured winter ever. It really is. We've had particular UEC challenges. We've had such a focus from NHS England and the government on long waiters, and our cancer performance has declined in part due to that focus. So there has been an increased demand on our diagnostics. Of course, there are all those national challenges around non-obstetric ultrasound. Our trusts have recovery plans in place. We are starting to see an improvement, and NHSE are closely supporting our most challenged provider quality. So green shoots there, fingers crossed. The other area of challenge is non-elective spells, and our inpatient flow in particular, which I know you're all aware of. Our inpatient non-elective spells have been above plan all year this year, and they've been above last year's levels. And there is some work that we're doing to offset, old and frail people being admitted. That doesn't seem to stop what's coming through, and it's still being admitted in the non-elective capacity. So more work to do in that space. And our patients waiting over 12 hours in ED is still, we have among the highest volumes nationally, and one of the higher percentages nationally too. So we are being supported by NHS England. They did an assessment in particular with a view to the mental health patients waiting 12 hours in ED. We think that that's going to have, the report has shown some specific actions that we can take that we haven't seen before. So we're quite hopeful that's going to have an impact too before the end of the winter. And finally, I've talked a lot, talking therapies, reliable recovery rates. So we have seen a slight decline. This year, NHS England had asked us to focus on the recovery metric for talking therapies rather than initial access at first appointment. Now, there is a finite spend and resource associated with talking therapies. So our mental health trusts have had to optimise their performance by shifting resource from the subsequent treatment and completed treatment to the first outpatient. And that's why we see that sort of a fluctuation in performance. But they did do a recent audit and they think that they have some areas of best practice that they can share between each other in South London and across London. So again, looking forward to some recovery in that space. That's it. Any questions?
Talks about non-elective, was it admissions you were talking about rather than attendances?
Sorry, admissions, did I say? I'm sorry.
No, I just wanted to know which it was.
Attendances went down in
But
December.
admissions
Went up, and all year non-elective admissions have been higher than they were last year and above plan.
Okay. And so the reductions in length of stay we've seen.
Probably resulting in more patients coming through the door just because the capacity.
Well, I just wanted to get your view on that. Is it because there's a bed available, or is it that it's the fact that we're seeing a higher acuity?
Yeah, sorry, the name's not sorry, Suzanne, but I think we mustn't forget that actually there are significantly less beds in the system this year because we took them out in Q1. So actually it isn't a conversion issue. I think it is an acuity issue, and actually an acuity mismatch with actually the pieces of work we've put in place around things like extending frailty estates are working and avoiding admissions. But certainly in this last period, consistent with the national picture, we have seen a much higher proportion of younger, more acute patients being admitted non-electively into the bed base. That isn't unique to South West London, and has been a feature of the earlier flu and the trio of flu, COVID and RSV together is impacting the cohort of non-vaccinated patients who are presenting this significant illness. And that is a national picture, but certainly something that we have observed and has been causing some of the really acute pressures, because we've been arriving in with just very small numbers of patients fit for discharge.
Thank you very much. Step into the bridge.
Thank you, Chair. Clearly, I'll take this report as read. It refers to a meeting that happened in October. We've had a subsequent to just this week, so I'll touch on that as well. We updated our discussions and thinking about the development of the broad assurance framework, so we're very comfortable with going in the right direction, but there's more work to do, and that's a function both of our changing roles going forward, but actually needing to think about articulating a fresh set of risks, because we're always at the end of this year, so this year's set of mitigations, but officers are on the case for that. We continued the idea of the strategic deep dive. We did performance in this report, and there's I think there's a lot of learning for us in terms of how we develop some of the more technical aspects of contract management and so forth going forward in the brave new world. And at the most recent audit committee, we spoke about quality, and again, a very good discussion about how quality remains important, but the lens through which we look at it may well change with the changing role. So all the thinking that officers are doing feels exactly to be in the right place. We received further update on external audit, although there's been a change in leadership in the external auditors, so there's some new relations to forge there, but the committee feels pretty comfortable about the way that the statutory audit, accounts and audit process for the organisation will run to the year end. Internal audit reviews are utterly on train. There's nothing. Most of the assurances coming through are good to very good. So I would expect to get a pretty clean and positive head of internal opinion going forward. and we received our usual updates on quite technical matters around single tender waivers and procurement process. And I mean, clearly the organisation has got a lot better in this space. The bad news is it's got to get a lot better again, particularly in the area of non-acute commissioning and contracting, which I recognise is a more complicated place, but that doesn't mean we don't have to get a bit better at it. But again, everything's on the right path, and we'll just stay on top of that going forward.
Questions? No? Okay, thank you very much. Remuneration committee then.
Thanks, Anne. I'm only doing this because Jamal isn't here today, but hopefully it's a very self-explanatory report, so I'll take it fresh and for any questions, happy to answer them.
No problem. Larissa.
Thank you. So following agreement of South West London and South East London boards to cluster, the HR departments working closely together, sharing approaches, best practice to support our respective workforces. We continue to offer colleagues a range of support offers, ranging from pension clinics, CWP benefits, advice and personal career support, and specific support for line managers as well to help their staff through change. At the end of last year, our colleagues were given the option to express an interest in taking voluntary redundancy with reference to the national agreed scheme. Work's progressing in that area. We meet regularly at staff sites, due to meet with them this afternoon, and we engage with staff on a weekly basis via AT's all-staff briefing. As referenced earlier in conversation today, further revised guidance on the model ICBs was issued in December, outlining functions that will remain. We've heard about EPRR, SDCs, and there's in relation to workforce transformation specifically, they've reviewed that to align with two of our four purposes as an ICB, that improving outcomes in population health and healthcare, and also that broader socio-economic development aspects. We're continuing a lot of work in that particular area, supporting local communities to access jobs in the NHS, engaging hundreds of local residents through engagement, training, development opportunities, often achieving quite strong conversion into jobs, not always in the healthcare space, I hasten to add, and apprenticeships and training. I'll say a bit more about that later. In support of our current workforce, the South West London Ask Auntie pioneering programme that we've developed within South West London, that's to particularly support our international staff. That's gone on to secure additional funding from NHS, and that's been rolled out across London. 19 organisations have signed up so far, and the app's also been developed to support social care colleagues and will be piloted from April this year. The programme also went on to receive a highly commendable Digital Improvement Award at the HSJ Awards last June. In terms of our workforce metrics, sickness across the systems increased from this time last year. It was 4.9% January 25. It's increased this year to 5.2. Cold and flu, the main reasons, it's that time of year. And we're also seeing an increase in musculoskeletal as well. Turnover's reduced, that's an interesting picture. So it was 11.6, it's now gone down to 9.6. And under normal circumstances, you'd think that was a good thing, a positive effect. But we suspect it's due to other issues that we're seeing taking place in the wider economy and job market. And we're also seeing lower vacancies within the NHS. We know, just mentioned, we're reducing, taking beds out. That's going to see a knock-on effect to vacancies that are then advertised. I'll come on to that later. Different picture within social care. So we're seeing an increased growth in job roles in social care, primarily care worker roles, due to increase by 8,000 by 2030, 10,000 by 2035. So a different picture there. And their turnover rates are quite different. They stand at 22.4%, slightly different issues.
things for the board to note in terms of risk. So workforce fatigue and disengagement is a continued concern for us. And we know there's lots of reform and change happening across the NHS infrastructure. We know also there's cost of living pressures and reduced discretionary effort. And we're seeing that in an increase in industrial action. We've seen rising rates of racism and verbal abuse and aggressive behaviour towards colleagues, and we're discussing that actively as a chief people officer community. And then just thinking about the 10-year plan and clinically led strategy and the 3 shifts, we know that there's going to be further shape to the workforce there to respond to population need. And given the scale of that change, we need to continue to support our workforce through that change so we don't see further disengagement and industrial action. In terms of anchor employer responsibilities, we're looking to continue that work and ensuring that we've got the right roles, right organisational structure that serves our community. We know, just referencing about the change in reduction in ward numbers or beds, that's had a knock-on effect to those who recently qualified in nursing or AHPs. That's impacted their ability to go into jobs, and we're working across the system and also with NHS colleagues in the regional space to support that. I didn't mention earlier, but this is not new. We've got an ageing workforce. 37% of our nursing workforce are over 50, which is an issue. So we need to be really mindful about our workforce planning in relation to that and how we match that reduced workforce that we're needing to see alongside the growth that we need to see around all the change, as I say, workforce models from a more into a neighbourhood health space. We're also working with higher education partners as well around that and social care colleagues just to do that proper workforce planning and ensure we don't have a mismatch or where we do to mitigate that as much as possible. And then just finally, just to talk about the launch of the inclusive talent strategy, Connect to Work and Work Well. I mentioned it here, I think this time last year, possibly longer ago, around Work Well. There are 15 pilot locations. They've reviewed the data and they're launching that now proper across the country. We're looking to work with South East London to think about how we can identify the best opportunities for our two communities in relation to that. Happy to take any questions.
Thank you. Very comprehensive.
Thank you, Larissa. I know from the report that when we look at sort of sickness, that a third of staff is because of mental health related issues. What are we doing to kind of support them?
So it's now we've done a lot of work on in the last few years, collectively working together across the system. There's mental health support clinics that we had, primarily Kingston, Croydon and St George's, to support the whole system, actually, not just staff working within those areas. Sadly, that comes to an end in March, so we've provided extra funding to support that service. Actually also extended out to primary care and social care as well. We had 2 funding sources for that. Was national funding on the back of COVID that was recognised at frontline staff, and it was actually extended to all staff in the NHS who are at risk of significant trauma through just the work, that the pressure they were working under and some of the things they were seeing, and that work continued, and that funding, I should say, continued for a time. That came to an end last year. We're able to further invest in it through the ICB programme the previous year, and it's come to an end this year. So going forwards, I know that from conversations with CPOs, chief people officers and the provider organisations, they're keen focus on how they can support their staff that are currently off sick. Not necessarily focused on mental health, but looking at all areas. But it is an area that we are going to have to come together and think about what we do, because we're not seeing reductions in that space.
Did we see an impact from the programmes over the last couple of years?
I think we did, yeah. Speaking to the psychotherapy leads that were leading those particular services, that early intervention, that early support was more preventative and preventing people from going off on long-term sick leave. Talking therapies have helped in that respect as well. But it did have an impact. We did latterly see sickness increase, that trauma aspect, as you would suspect, a delayed response to COVID. Yeah, there were improvements, but I think we're going to see a changing picture as that support subsides going forwards.
So again, just to raise a concern, we've got all these plans and we've talked about workforce fragility, and then we've got a major kind of driver that we're aware of, the third. Perhaps it's just raising it as a concern that
We'd like to.
what are we going to do?
You'd see a similar pattern across the whole of the NHS.
Yeah. And we're seeing it play out through other actions, aren't we? I mentioned earlier, industrial action, discretionary efforts reducing. People are tired. So it's not just a case of mental health, there are other things and aspects that we need to look at. How do we support our workforce at this time? It's challenging.
So I think one of the things we might want to look at is the flip side of what you described in your research, to say, how do we track staff engagement? Because we know that as a metric, that's probably the most reliable metric in relation to the success of any organisation, be it NHS or not. I mean, that's well evidenced. So I guess one of the things maybe to think about, and obviously with Michael West's work in terms of the quality of outcome as well, in an NHS context, I'm just wondering whether it's something we should think about going forward in terms of what's the basket of metrics from a commissioning perspective you'd want to think about in terms of how do you measure that. Because what we're describing is the flip side of it, which is high sickness absence, industrial action, which is disengagement, and what actually we want is engagement. So it might be helpful to look at that. And the other thing that just occurs to me is, do we need to look at workforce productivity? Simply because, we said earlier in the meeting, we needed to reduce the headcount because it grew so much over during the COVID period. And I don't know whether that's right or wrong. But the narrative we've got at the moment, being dispassionate about it, is numbers of staff have gone up significantly, but numbers of episodes, the rate of people being treated has slowed. So case per member of staff, let's put it that way. And I wonder whether that's something we really, because it's something we're being asked, and there may well be very good reasons in terms of safe staffing levels or whatever, but is that something we track, or is it something we need to track and start to look at it as a system?
Is it a worthwhile evaluation? Because again, the complexity of what we're talking about, it feels like we are trying to distill it down to certain metrics that frankly don't represent the complexity of what we're trying to assess. There's so many different factors. We're saying increase numbers, therefore we should have increased productivity, but the complexity of cases, the acuity, plus our workforce. We're talking about workforce fragility and what they're able to do. They're already. It feels like everyone's running at full pace, burning out, and we're seeing the impact of that. And yet we're still trying to distill it down to some metrics that.
What's the narrative, I guess, as well.
That's the narrative above us.
Yeah.
So yes and no. It is complex and multifaceted, but there is absolutely sort of clear evidence that the increase in numbers hasn't necessarily gone into the places that will deliver, better outcomes and experience for both patients and staff, because we know that that's two sides of the same coin. And a lot of this has been driven by, the phraseology. I don't like the phraseology that is checkers rather than doers, that type of thing, and Elaine, I know will, because she said to me on a number of occasions, the exasperation in terms of really senior experienced clinical nurses who are patient facing because of the amount of checking that they're required to do. Some of it's legitimate and additive, some of it is not. So I do think there is merit in looking at a productivity set of metrics, but being clear and but circumspect about what they are, rather than just assuming that's going to solve the issue. But there is something, and certainly the kind of data science approach to our CLSP shows that there is an absolute clear and specific workforce productivity opportunity has yet to be quantified, but there is an opportunity in South West London. So therefore, by definition, we must look at it, but we must look at it in a way that's value adding, as you say, rather than it being purely a two-dimensional increased numbers, reduced episodes per patient, because that's what that apples and turnips that we're doing. But we need to get that right. But I think absolutely at the heart of what Anne is talking about around the engagement score is absolutely something that we could and should place into sort of a balanced scorecard as a strategic commissioner within our contracts, because the evidence is so barn door that more engaged, better valued, more motivated workforce where turnover is reduced and sickness is reduced, reduces deaths in hospitals and improves patient outcomes and out of hospital. It's that case is proven, and so it would make complete sense to do that. But I agree, it's not the spray and pray approach to metrics where we have 50, but the small number of high value ones, of which I would agree staff engagement has to be one. And we don't tend to do it because it's not the way we collect our data currently, and therefore it's not so easy. But every other industry does it really well. So we just need to do what they do and require it in our contracts. But whilst we look at things like, the mental health piece is a reflection and a mirror of what's happening in UK PLC, isn't it? It isn't just in health. And what we need to do is what can we do within our context to create a working environment that's psychologically safe, provides that security where people feel valued and motivated and engaged, that will do as much as we can to reduce people's feelings of what's largely there to be anxiety and depression, which lead to absence from work. So that was quite.
Thank you, Nancy. I mean, Anne's totally right. I think the stuff that is published nationally, so it's all based around the queue. And I have to go talk about this. I've got some numbers in front of me, shows that weighted activity, so when you look at the relative complexity of the activity, so acute spend weighted for relative complexity has gone up by about 20%. Whole time equivalence, this over 10 years, has gone up by about 35%, but activity again weighted has gone down by 14%. So you're absolutely right. That's the national message. Each acute provider, and they just started doing it for mental health because it's taken a while to work it out, already gets its own weighted productivity score. I'm not sure if it's quarterly because I don't see the acute stuff. And I wonder if there's something, rather than reinventing the wheel, we think about how we can pull that data or use regional data to bring something together. I think otherwise we're just reinventing the wheel again. But that's what NHS will be challenging each provider to improve.
Yeah, and I think just understanding it. So, for example, a legitimate reason why that might be happening is lack of diagnostics. It's nothing to do with the staff, it's to do with the fact that they can't get, the MRI scanner keeps breaking down or whatever, because that hasn't been captured. Now, as commissioners, we need to know that, because that's a major block to the productivity of the system. But at the moment, we don't measure it. Thank you. Thanks, Lisa. Anything else on that? Organisational thought, Katie?
Yeah, I mean, I'll just take it as read. I'm very happy to take any questions, but really this is an opportunity to provide the board with information on other things and activities that our people or services are taking part in across the system. So I think a lot of the items we've already covered under other items, but happy to take any questions. So it's anything that was flagged from it.
What's the thing when you come at the end of the meeting that that's probably a good thing. Any other business from anybody? No? Okay, so I move to close the meeting, and we haven't received any written questions from members of the public, but we do have some people with us, so if anybody would like to ask a question, please feel free to do so. Actually, you could say who you are if you. Nothing this time.
Yeah, I don't have anything to add. Yeah, it's likewise.
Well, thanks for coming in. Okay, I think that means we can draw the meeting to a close. Thank you very much.
Thank you.